Dr. Itu, it's 3 o'clock. Should we just kickstart it now?
Yes, please, we can start.
Okay. Good afternoon, everyone. You are welcome to the November series of our webinar for Society, Guilds of Pediatrician and Private Practice. And I've done this back to back. And today is an interesting topic we're actually dealing with, and we have an expert in the house. So I'll just yield to the chairman to make his opening remarks before we start the meeting. Thank you, sir. Dr. Leto, over to you, sir.
Okay, thank you very much, Tunde. First, I want to say a big thank you to all the participants who have joined, particularly Dr. Mbolaji Lawal, Dr. Aroshodipo, I think Dr. Fakunle from the UK and the US are here as well with us, and every other person who has logged in. The topic for today is diphtheria in Nigeria, a reimagined disease. Where are we and what is the way forward? I'm sure most of us will be alarmed that we're still talking about diphtheria in 2025, and we're aware of what's been going on, particularly in the northern part of Nigeria, Kano, for instance, and then by extension, we had an epidemic in Lagos. So that's why this topic is very, very important for us to discuss. And like Dr. Dushote said, we have an expert in the house who will guide us as to what to do. So I yield back to you, Dr. Dushote. Thank you. Welcome again.
Thank you very much, sir, my chairman. Like we said, we have this important entity that we believe that should be a thing of the past, but hey, we see how it goes. So to do just the topic is my dear sister, Dr. Patricia Akintan, a graduate of University of Lagos, and he has a master's degree in public health from University of Lagos, and she's a fellow of National Medical College of Nigeria, and has a master's degree in University of Dundee. And I can say without a fact, because we are from the same stock, she is a certified ID specialist. She trained at the Royal War Memorial College Hospital in Cape Town. She has the College of Certificates certification in that field. She's a consultant pediatrician in Lagos University Hospital and also a lecturer at the College of Medicine. She's passionate about infectious diseases with interest in TB, HIV, malaria, and epidemic-prone diseases. She's authored many publications in learned journals, local and national journals, and she's actually passionate about child well-being and advocates for child rights and welfare. So I don't think there's any other person that can do justice to somebody who is passionate about what we are talking about, and infectious disease, which is something that we need to learn. Like we also know there is reimagined, and we need to know what's the path forward for us as pediatricians. So Dr. Patricia, please, is your time. I'm yielding to you, so go for it. Thank you. You can unmute now and go for it, Dr. Akintan.
Good afternoon. Good afternoon, everyone. Good afternoon, senior colleagues. Thank you for the opportunity to just give this talk. I just want to be sure that everyone is hearing me.
Loud and clear.
All here?
You are audible.
Okay.
Yeah, loud and clear.
All right.
Thank you.
So I want to hear me. Just let me know so I can change my internet. I'm just switching between 1 and 2. So good afternoon, everyone again. My name is Dr. Akintan. Thank you, sir, for the introduction. This afternoon I'll be talking about diphtheria in Nigeria, a re-emerging disease. Where are we and what is the way forward? I went for my training 2013. I left diphtheria behind and I came back and we still have diphtheria here. So there's something we need to do. So I'll just go on. So this is just my slide. Is it moving? Okay, I'm moving. Sorry. So this is the outline I'll be using. I'll do a little bit of introduction, talk about epidemiology, pathogenesis, look at clinical features and some of the cases, few cases we've seen, maybe pictures, investigations we need to do, look at treatment, what are the options, what are the complications, the prognosis we have in our environment and what do they have outside our country. We look at prevention and how we also have to look at how protected are our children. Are they protected at all? Then the way forward, then we'll conclude. So my introduction, diphtheria is an acute bacterial disease caused by toxins produced by strains of coronary diphtheria, and the infection results in either a respiratory or a non-respiratory disease. The non-respiratory disease is usually a cutaneous manifestation. So it's an aerobe and it's non-encapsulated, it's non-spore forming, it's non-motile, and it's a gram-positive bacilli. There are very few gram-positive bacilli. There are basically two toxigenic strains of coronary bacteria apart from coronary diphtheria, the coronary bacterium ulcerans and the coronary bacteria pseudotuberculosis. These primarily cause zoonotic infections, but they can also cause infections in humans. So basically what diphtheria does is to produce a toxin, which is a toxigenicity. And it can't produce these toxins unless it's infected by a virus called a bacteriophage. The bacteriophage carries the genetic information for the toxins, and that's why it begins to produce toxins. The non-toxin producing strain of diphtheria can cause disease and is generally less severe. They usually cause very mild sore throat and rarely a membranous pharyngitis. It's probably a disease of childhood, and but also can affect adults. We have seen adults with diphtheria. I had one case of adult with diphtheria in LUTH, and I think the other Lagos State hospitals have seen one or two of adults. There is no racial or gender predilection. They have epidemics in our outbreak in other areas, like in Southeast Asia in 2011, where they had 71% of the cases they saw, about 5,000 cases were mainly from India. Recently in 2022, that's about 3 years ago, they had 144 cases from Europe, Austria, France, Germany, Italy, and Norway, and Switzerland and the UK. So they're seeing pockets of infections in other parts of the world as well. In Nigeria, we had an epidemic in 2011 in a village called Kimba in northwestern Nigeria in Borno State, where they had 98 cases. All those cases were not immunized against diphtheria, and none of them got any treatment, either antitoxin, penicillin, or erythromycin, and the case fatality was 21.4%. Recently, WHO has declared that Nigeria had about half of the cases of the diphtheria they've seen worldwide. They had 27,778 cases in 2023, and half of them came from Nigeria. So this is a recent map from the NCDC. I got it from NDC. This is the latest updates they have as of week 18, EPID week 18, which is around May. The areas with the red background now, areas where diphtheria is thriving. Kano is the epicenter now. Kano, Yobe, Borno, Bauchi, Gombe, Jigawa, Katsina, Zaria, Kebbi, Kaduna, Ogun, Edo, Imo, Abia. Lagos is not showing here, and I think it's because of our population. Lagos has about 20 to 25 million. So when you look at the number we have, it's going to swallow it up. So it's not going to give any significant result. But we are having cases in Lagos presently. We had one 2 weeks ago. The last one was 2 weeks ago. So this is still showing the EPID curve, showing the cases. You look at the brown part, that is the clinically compatible cases. Those are patients who present, adults and children who present with cases that look like diphtheria. But however, we are having very low laboratory confirmed cases, and we are going to talk about that. Why are we having very low lab confirmed cases? So this is also the statistics from NCDC. I'm going to focus on Lagos because that's where I'm domiciled. In Lagos, we've had 131 cases as of May this year. We only had 10% confirmation. So only 13 of them were confirmed, and they had a 69% mortality. Mortality in Lagos is somehow higher than other parts. Kano seems to have a lower mortality now than Lagos. Even though Kano had more cases and Kano had more confirmed cases, the reasons are also known why Kano had more confirmed cases. So, that's why we have diphtheria. Can we use the figures are there? To of the statistics for 43,000 so far. So maybe
Hello, Dr. Akito. You are breaking up. So maybe you should switch off your video.
so 6,000 so actually. Hello?
Okay, we can hear you now.
Yeah, I don't know why you stopped hearing me. I think the internet went off. Can you still see my screen?
No, we can't. So you need to share it again.
I need to unshare. Sorry. I have to change my. Sorry about that. I'll switch my internet again. Can you see my screen now?
Yes, you started sharing, but you're yet to see it.
Okay, let's see.
Yes, okay, we can see now. I think the slide before this one is where you stopped. The one
Okay.
before this.
Okay. Yeah, I'm continuing. So I'll go back. Okay. Is that fine now?
Yes, correct.
So I might need to turn off my video. I don't think that's affecting my.
That will
Okay.
be fine.
So these are the cases they've had. So 19% of them were, only 19% of the cases were fully vaccinated. So this is just a summary of what I was speaking about just now. So they have a case fatality of 5.2% in Nigeria. And out of the total number they've had. So what are the risk factors for diphtheria? We've seen basically most of the patients had incomplete immunization. Most of the patients we had in LUTH were 7 years and above. Some of them only stopped at 1 year, had vaccination last when they were 1 year old. So they had incomplete, they never got a booster. But recently we had a couple of 3 children who were immunized. They were 3 years old, they had their vaccination up to date, but they came down with diphtheria. So we are still trying to decipher what really happened. We saw their vaccination card and actually got vaccinated. So low herd immunity is another one. When you don't have enough people being immunized, then you have a group of people who don't have protection. Those ones seem to get infected. Then low socioeconomic status, you know, the country, everybody is Nigeria is going through some economic challenges. People get low pay and high cost of living. People aren't feeding well. So and then overcrowding, the cost of housing is enormous. So a lot of people tend to stay in smaller spaces now. And of course, most of the houses constructed now are actually very small in size. There are people who travel to endemic areas and immunocompromised individuals. Out of our patients, we have some patients who are about 3 patients who have sickle cell disease and they tend to have more severe disease. So what coronary bacteria does is to produce toxin. It exclusively stays in the human mucosa, in the membrane and in the skin, and is spread by droplets. So when people come in contact with the secretion from a symptomatic individual, then they get infected, or either from exudates from the skin or lesions. There are a group of people who are the asymptomatic tract carriers, and these people tend to carry the organism in their airway, and they are good transmitters of this organism. So it produces an exotoxin which inhibits protein synthesis and causes local tissue necrosis and resultant local inflammation. So both the toxigenic and the non-toxigenic strains of coronary bacteria can cause skin and mucosal infection. The clinical features, incubation periods, a median of 2 to 5 days, but it can be a range of 1 to 10 days. And usually the clinical feature depends on the site of affectation. If it's a respiratory diphtheria, then usually more of it's a respiratory tract areas that you get the symptoms. The respiratory diphtheria has three forms. The nasal diphtheria, where they have a serosanguineous or seropurulent nasal discharge. So in an endemic area, you might find a child who will just have nasal discharge. So you shouldn't, that's the patient you should actually take samples for too, because they might not have the membrane at that stage. Then the pharyngeal or tonsillar diphtheria, which is the common type we see in Lagos here. Then the laryngeal diphtheria. We've had one patient who had cutaneous diphtheria, but had cutaneous diphtheria with the pharyngeal diphtheria. Sorry, I'm having problem trying to move my slide. So the respiratory diphtheria has a gradual onset and is characterized by a mild fever. Most of them don't have a high fever, but they usually have almost all of them have a sore throat and have difficulty in swallowing, and they have a malaise with other symptoms. They have loss of appetite. They have hoarseness of the voices, dyspnea or stridor, and some of them can have wheezing. I remember in 2019 when we first had our first case of diphtheria after a long break. We hadn't seen for a long time. And that child just walked to the emergency room on a Sunday afternoon. If you walk past her, you think she was an asthmatic child. And everybody say, oh, she's asthmatic. And the mom says she's not, but they thought she was asthmatic and they were nebulizing her. She never got well. Somebody just said, oh, why don't you even check this room? Maybe it might even be a foreign body. And then that was the membrane was there everywhere. Then she had a tracheostomy done. And I was happy that that child survived and went home. So, so the pseudomembrane is a hallmark of the respiratory diphtheria, like we said, and it appears about 2 to 3 days of the illness. It spreads over the tonsils, the larynx, and the nose, and it composed of the organism, the bacteria itself, the epithelial cells, the fibrin, the leukocyte, and the erythrocyte. It's difficult to remove, and when they try to remove it, it tends to bleed. And it can cause fatal obstruction because it goes around the whole of the pseudomembrane, can go around the larynx, the trachea, and it can actually gets dislodged and block the airway. Then the bull's neck is secondary to lymph nodes, large lymph nodes, and soft tissue swelling edema. So sometimes some literatures of people have described otitis externa in children with diphtheria. People have described children with adults with purulent or ulcerative conjunctivitis. In Kano, I know in Kano that when we saw in Abuja, they have some cases of genital tract diphtheria where they had membrane covering the vagina. So that can happen. Then we've had children with osteomyelitis and septic arthritis in some of our patients. Now, I'll just look at the cases we've seen. So like I said, we first saw our first case in recent times in 2019. Then we didn't see any again for about a year. Then the next year, 2020, during the COVID period, we had this first set of children from one family. All of them had diphtheria. We lost one because the parent had declined tracheostomy and discharged and went home. Then they came back after they lost the child at home. So after that, from 2019 to 2024, we've had 34 cases in our record in LUTH alone. Other hospitals have been having some other cases. Jeremy told me they've had like 9. In 2025 alone in LUTH, we've had 18 cases. So I don't think this outbreak is actually but it's still with us. If we've had 18 cases from January till now in 1 year, then it's the thing of concern. It's significant. So these are some of the pictures that I have. You see the membrane, the white one. Let me just get my pointer. Okay, so we have a membrane. This is the membrane of some of our patients. These are our patients in LUTH. This is another one in the membrane at the back. This one had a very extensive membrane covering everywhere. This child could hardly breathe. At the back, this child had a tract. Then this is the most recent one. She had membrane everywhere, very extensive. Once she opened her mouth, you just see everything around. The whole of the pharynx everywhere, right to the back of the throat, was all covered by the membrane. So they can also have some systemic manifestation when the toxins get absorbed into the circulation. So they can have acute tubular necrosis. They can have thrombocytopenia. 1/3 of our patients had thrombocytopenia. They can have cardiomyopathy. About half of our patients have cardiac complication, and that's the major cause of our own mortality. Then demyelination of the nerve. We've not had any patient with demyelination of the nerve recently, but I know that a few years ago, we had a patient that had polyneuropathy, and when they investigated further, they found out that she had had symptoms that suggestive of diphtheria in the past, in the few months before she came. So they can have encephalitis, but it's rare and it's common in the extremes of life. The cardiac complications manifest in 2/3 of the patient. Some centers, they have 10 to 25% of them having cardiac manifestation. And the risk of cardiac manifestation depends on the extent of the disease. So if you have very severe disease, the risk of cardiac manifestation is going to be higher. And they cause about 2/3 of the mortality. So they have congestive cardiac failure, or they can have circulatory collapse. Sometimes the cardiac manifestation is in the early stage, sometimes in the later stage. I remember a patient that we had managed him for 2 weeks, and we were happy, and he was about to go. Then he suddenly developed the cardiac manifestation, and we lost that patient. So it can happen at any point during the illness. Even when they go home, sometimes they come back with those complications. The neurologic complication, they have regurgitation of fees, and they can lose their regurgitation of fees, and it can lead to aspiration. They can have cranial neuropathies. They can have asymmetric demyelinating neuropathy, which we've talked about, and the recovery is very slow, but they usually recover completely. So when you have a patient that I think has diphtheria, one of the first things you must do is to take a swab. Because I was discussing with the microbiology, some of the reasons why we don't have positive cultures from Lagos is because most of the patients would have started antibiotics from somewhere, and the swab weren't taken properly, or wasn't stored properly, or wasn't transported well. So we were having low positivity rates in Lagos. But all the patients we saw they are clinically compatible with diphtheria. They had clear membranes, the symptoms were diphtheria. So you need to take a sample from the nasal or the oral pharynx and mucosa or any cutaneous lesions that are available. It's advisable that you take the sample from underneath the membrane, or you take a portion of the membrane if it's possible. And you should take a sample with a swab stick that's embedded in the transport medium. When we reviewed what we were doing, I found out that we were taking samples with dry swab, and there was a delay in taking it to the lab. So most of the organisms were dying. So we spoke to NCDC, the Lagos office, and they gave us this tube where we could use a dry swab. We just break it and put it into the transport. This is the membrane. So we embedded in this membrane, and we started getting positive results. So the dry swabs are not recommended. This is just a sample of some of the diphtheria antitoxins that we have available, one of the doses that they brought for us from Lagos State. So, but if you have a patient who have diphtheria, you have to take a sample, but you should not delay treatment while waiting for results. Once you can take your sample, start treatment immediately. So the lab will do a culture, and they will send the isolate to NCDC to do the ELIC test or the PCR. Other investigation depend on what the complications are, like electrolytes, urea, and creatinine, or you might want to do a platelet count, because they usually have thrombocytopenia. So you do a full blood count just to check up their results. In terms of managing them, it's a multidisciplinary care. You need almost everybody involved to manage diphtheria. The infectious disease pediatrician or physician, if it's an adult, needs to be in the forefront in the care of this patient. You need a nursing services. You need a nursing care. Nursing care is very important. Diphtheria is just like tetanus. If you don't have good nursing care, your patient might not survive, especially if they have a tracheostomy. Somebody needs to suction that tracheostomy very regularly. The first patient we had, we almost lost her because everybody was scared of diphtheria. Nobody wanted to go near the patient. We, however, got a very bold young nurse who was bold enough to stay around the child every time. And that child was happily survived and went home. You need a microbiologist to take your samples, and you need to call the lab that you're sending a sample so that they can get prepared and plate it as soon as possible. You need a public health response, the public health specialist, because you need to do contact tracing. You might need a nephrologist if they have AKI. The ENT and anesthetists have been part of our team here. Usually when we get a call from Mercy or one of those hospitals that we have a child with respiratory distress, we just call the ENT surgeons, and usually they are waiting in the emergency room to take the child to theater and give an intervention immediately, especially if they have an airway obstruction. You need a neurologist and you need a cardiologist. So in terms of treatment, we don't wait for confirmation before we start treatment. You need to isolate all the cases, all the patients that you think have diphtheria. If a patient has diphtheria, you need to isolate the patient, do universal and droplet precautions, and you limit the number of contacts that child has with anybody. So avoid moving the patient from one place to the other. If they need an X-ray, if you have a portable X-ray, bring the X-ray to the patient. If they need to do ECG, bring the ECG to the patient. But if you don't have a portable one, then you need to alert the radiology center that you are bringing a patient that you think has diphtheria, and they need to be protected too, because the health workers need to be protected. And you have to avoid unnecessary movement of the patient anywhere. And if you have to move the patient, then the patient needs to have a surgical mask on while they are moving. And you need to notify the authorities. Usually we do it through the public health physicians, or we call the DSNO, because they need to go to the community and find out what is happening in the community and take samples and contact trace. So in terms of management, we have the emergency management. We have to neutralize the toxin. You have to eradicate the organisms, anticipate treatment, and supportive treatment. Those are the principles of management. Emergency management, we'll talk a bit about it. It might involve giving a tracheostomy if they have, so the patient, if they have airway obstruction, upper airway obstruction, or if there's an impending upper airway obstruction. Circulatory failure, you need to give fluids, you need to give them oxygen, you need to do their ECG, because they might develop the cardiac complications early. You need to neutralize the toxins, giving the diphtheria antitoxin, the DATs. So we have them available, and it's a gold standard for treatment. And it acts by neutralizing the unbound diphtheria toxins in the blood. So you need to give it early. We don't wait for laboratory confirmation before we give the antidote. It's advised that if you have a patient that is clinically compatible with diphtheria, you need to give that child antitoxin if you have it available. It's better to give it and it turns out not to be diphtheria than not to give, and it turns out to be diphtheria. So what it does is that it binds the circulating toxins in the blood. But however, if you don't give the antitoxins, the toxins that have bound already in the system is not affected by the DAT. And if you give that, it reduces the complication and mortality significantly. So they also recommend that you do hypersensitivity testing. But I know that in some centers now, they've said, like in South Africa, they remove hypersensitivity testing from their guideline. They say it's not required. They don't have a lot of reactions to that, and they've stopped doing hypersensitivity testing. So this is a dose of that. It's not age dependent. It's based on the symptoms of the patient. If you look at the national guideline, the NCDC guideline, the doses are there. There might be a few variation. If you look at MSF guidelines, a little bit, but the minimum dose is always the same, but it's the range that differs. So if a patient has laryngitis or pharyngitis and the duration is less than 48 hours, they get 20,000 international units. It's given in an infusion with normal saline over 2 to 4 hours. If they have a nasopharyngeal disease and they have an extensive membrane and the duration is less than 48 hours, they get 40,000. If they have one or more of this, like diffuse neck swelling and any disease more than 48 hours or severe diseases like respiratory distress or shock, then they get at least 80,000 international units. I know in Abuja, like 3 years ago, when we were drawing up that guideline, we agreed that we should not give more than 80,000 units, that some of the patients were having some serum sickness-like reactions to the medication. So in LUTH, we don't usually give more than 80,000 units to patients anymore. So in terms of eradicating the organism, the antibiotics that is commonly recommended are the macrolides, the erythromycin and azithromycin. That's what we have available. Unfortunately, we don't have the parenteral form. So we have difficulties making these children to swallow these antibiotics. They cannot swallow. They've done a lot of, if you go, you see a lot of research that has been done on antibiotics treatment for diphtheria. And clearly it's been shown that erythromycin has a better advantage than erythromycin, and the outcome is better, mortality is less. But however, there are some new publications that are started showing endemic erythromycin resistance in some children in Vietnam as early as the 1990s. So there are some resistant to erythromycin already. And they are also resistant to ceftriaxone also in some centers. But in CDC recommends that if in areas where you have some drug resistant, ceftriaxone can be your drug of choice. So what we do here, we do ceftriaxone IV while we are attempting to make them swallow the macrolides. That's what we do commonly in our own center. And you should give antibiotics as soon as possible. Now, there's this worrisome recent publication where they've seen that there are some strains of coronary diphtheria that are multi-drug resistant, and that is where the worry is. Now, we have a sickness that is a disease that is that has a high case fatality, And we are also seeing the bacteria developing multi-resistant strains. So this is a cause of worry. Even though they said that in such situations, you could use linezolid or vancomycin, but I clearly didn't find any papers to support that justification in my search. So this is Nigerian antibiogram. This is a Nigerian report from NCDC. And we can see that penicillin is a no-no now. We can't use penicillin. It's virtually not really useful because most of it is resistant and indeterminate, so we can't use it. Cefotaxime is the same. And that's what we have in LUTH. So LUTH, the microbiology tells me that cefotaxime they were all resistant to cefotaxime, but they are sensitive to ceftriaxone. Quinolones are not useful. Septrin is not very useful, very small percentage of susceptibility to septrin. Tetracycline has a good 80% sensitivity, but however, in children less than 8 years, people shy away from tetracycline because of the effect. So the macrolides are actually the only one that we have left for us to use now. In terms of recent updates, I found this interesting where they are trying to look at monoclonal antibodies to treat diphtheria. To manufacture that is very expensive because they need to inject it into horse, and extracting it is very difficult. Unlike tetanus, where you have tetanus immunoglobulin, they've not been able to manufacture diphtheria human immunoglobulin because it's difficult to get. So they've done this, they've looked at these monoclonal antibodies and they've compared them with the equine diphtheria antitoxin, and they found out that they are almost comparable and are equally as effective. So that's the new area that they are trying to research into to get monoclonal antibodies to treat diphtheria. And we are hoping that this will be a breakthrough for people with diphtheria. So you need to anticipate complications like the cardiac complications like we talked about, and do your ECG, and there will be PR interval changes, ST wave changes. You might have dilated cardiomyopathy and heart failure. So you need to put that at the back of your mind when you're treating them. In centers where they have pacemakers, they give these children pacemakers, and the children do well on these pacemakers. The neurologic complication, you are really not much you can do. Steroids are not beneficial, but they recover on their own. The renal complication, with the help of nephrologists restricting fluid and stopping nephrotoxic drug, they usually will recover on their own. They could have complication of pneumonia, and usually when they do, it wasn't the prognosis. Just to know that very rarely you can have some non-toxigenic strains of of bacteria, of Corynebacterium that can cause endocarditis, myocardic aneurysm, osteomyelitis, and septic arthritis, and they have a very high mortality. So the supportive care is regular supplement of tracheostomy. That's why the nursing care is very important. You must ensure adequate fluid and electrolytes. You must give them pain and fever control. Then avoid frequent examinations. So avoid invasive procedures as much as possible, and don't disturb them unnecessarily. For every child who has diphtheria, the child must be vaccinated before they are discharged, either while in the hospital before they are discharged, because it does not give lifelong protection. So the child can come back with diphtheria again. So it's unfortunate for a child to have diphtheria twice in his lifetime. So they must be vaccinated. So the differential diagnosis that might confuse us with diphtheria include epiglottitis, retropharyngeal abscesses, angioedema, exudative tonsillitis. Exudative tonsillitis can be very confusing with diphtheria sometimes, but diphtheria has a clear membrane. So if you're able to examine the child, the membrane is there, that is very distinct. Then infectious mononucleosis, which is not very common with us here, but it does occur. Peritonsillar abscess, pharyngitis, and oral candidiasis. In our 3 children who were less than 3 years old, this is the first time in Lagos, in LUTH, we are seeing children who are less than 3 that had diphtheria. 2 of them had oral candidiasis as well, in addition to the Corynebacteria that they had. So the prognosis is multiple. It depends on the age of onset. Children who are less than 5 years old and adults who are less than 40 have a poor prognosis. The duration of symptoms also, if the symptom is more than 4 days, then the prognosis is mortality is higher if they present late to the hospital. If they've not been vaccinated, mortality is higher. If the antitoxins is not given early enough, mortality is higher. If they have cardiac complications, mortality is higher. All our patients that die from the cardiac complication. And if they have other systemic diseases, then the mortality is higher. Other centers will say mortality is about 5 to 10%, but our mortality here is much more higher than that. So in terms of the public health response, you must identify close contacts and all household members. Anybody who has slept in the same house on the tent in the last 5 days is a contact. Or any person who has stayed close to the patient less than 1 meter away or for a prolonged period over 1 hour in the last 5 days is a contact. Then the medical staffs are also contacts. Sometimes this patient comes and people let down their guard and they didn't realize what diphtheria. They are also contacts and they need to be taken care of also. So you need to collect information from the contacts and about the outbreak and keep a tab on the contacts. Ideally, all the contacts should have a throat swab done, and they should be put on prophylaxis until the result is available. So this is the treatment for the contacts that they give erythromycin or azithromycin, and usually for 7 days until you get your result. And they should be excluded from work or from school for 48 hours. Until the antibiotics have completed 48 hours. Recent studies said that by 48 hours, you should have eliminated most of the organisms in the airway, in the throat. So you ask them to assess for signs and symptoms at home, and if they have any new development or any sign and symptoms suggestions of the respiratory tract infection, then they must seek help immediately. So there's a group of people, the asymptomatic carriers, you give them, now you've taken a throat swab from your contact and some of them were positive. Those ones should have antibiotics for 10 to 14 days. And you must give age-appropriate preparation of vaccination to them if they've not been given a booster in the last 1 year. And they should also ensure droplet precautions until they've done 2 consecutive cultures, which is done 24 hours apart after they stop antibiotics. Now, for cases, people who have cases and who are carriers, it's recommended that after 2 weeks, again, you do another throat swab. And if they are still positive, you must give them another course of antibiotics for 10 days. You need to ensure that they are eradicated, because these are the group of people that stay in the community and begin to transmit the infection. So prevention is the 5 levels of prevention: the general health promotion, housing, overcrowding, nutrition. That is not really, that is outside the scope of our work as doctors, but we can also make advocacy for that. Then specific protection, immunization, contact tracing, and chemoprophylaxis. You need to detect it early. If you think it's diphtheria, please act early. Don't wait for cultures, because the patient might not survive. Then limit disabilities by giving your antiarrhythmic drug, anticonvulsants, suction regularly, and rehabilitation with physiotherapy if they have polyneuropathies. Now, in terms of prevention, I'm going to dwell a bit of that. Vaccination is the most crucial step in preventing the disease. And the diphtheria vaccine is made from inactivated diphtheria toxin. Generally, there are different formulations. What we have in Nigeria is the high-potency vaccine, the big D, DPT. That's what we have in Nigeria, and it's encompassed in our pentavalent vaccine. Other centers, you can have things like Tdap, DTAB, TD, and the big D and the small T, the full strength and the modified strength. So for a child to be fully immunized from diphtheria, to be fully protected, they need at least 6 doses of the vaccine. They need 3 primary doses, which is given at 6 weeks and 10 weeks, 6, 10, and 14 weeks. Then they need 3 booster doses of the high potency formulation. And that should be given, the 4th one should be given between 12 to 23 months. In Nigeria, we are still finding it difficult. A lot of mothers stop at 1 month, and you ask them, they say, oh, I've completed my immunization. My child has finished my completed immunization. They don't go back to take the booster doses. Then another one should begin at 4 to 7 years of age. Then by the time they are 9 to 15 years, you give them the reduced strength. That's why you can do the Tdap or the TD, the small one, the small T and the big T and the small D at 9 to 15 years. Ideally, the booster doses should be given 4 years apart. And it's advisable that people should get booster doses every 10 years. I looked at vaccination in the UK, coverage in the UK. they have 91 to 95% since 1990 to date. In Nigeria, we had 33% in 2017. 2021 had 56%. Currently, it's hovering around 60%. So we haven't covered our children enough, and that's why we're having diphtheria. And to support this, a lot of publications have come out. Look at vaccination coverage in the geopolitical zones of Nigeria. In 2017, Lagos had 100%, but now Lagos has 80%. Initially, most of the other regions were below 50%, and they improved in 2011. But it seems in 2021, a lot of them have dropped back. None of them has up to 90%. So we haven't covered our children enough, and that's why we are having outbreaks. And they also, in that paper, this paper also said that that the urban children were better protected than the rural children, but another paper gave a contrary opinion. So this is still immunization coverage for Nigeria. Lagos is still topping, about 80%. Most of the other states have very low immunization coverage. And when you look at the map, you now see why the children in those areas have diphtheria. So even though the child has primary vaccination, the first 3, studies have shown that for every year, there's a decrease of 0.4% every year since vaccination. So the immunity actually goes down. The antibody level goes down. So the full vaccination with 3 or more doses has been shown to give 87% protection against symptomatic disease. But if they've had 5 doses, then the chances of them of getting diphtheria is reduced by 99% with 5 doses. And it's also 81% effective in preventing severe disease. Now, the 3 doses that the children get have been estimated to reduce transmission by 60%. So that's why they say for asymptomatic carrier, you should vaccinate them so that you reduce their chances of transmitting it to other people in the community. So this is still from Nigerian data. This is the number of people who have died from diphtheria in the last 3 years. The red parts are those that were not vaccinated. So in every age group, the people who were not vaccinated are the ones who were dying more. So vaccination is key for us to stop diphtheria transmission. So I also went back to look at the global statistics. This is a systematic review and meta-analysis with a multi-level regression. And the antibody cutoff from that systematic analysis was that for you to be protected, you need at least 0.1 international unit for seroprotection. And in this review, they found out that the African region had a lower seroprotectivity compared to other regions. And that after 2015, the disease had re-emerged globally because most of the seroprotection levels were below 50%. That's why we are having diphtheria now, because most of the people are not protected. Then the Nigerian study did by some of the staff of NCDC and some other international researchers. I'll just look at a bit of that study. If you look at this map of Nigeria clearly now, this is for people who have minimal protection, and they define minimal protection as 0.01. Remember, full protection is 0.1. 84.3% of children aged less than 15 years had minimal protection. But for full protection, it was 41.7%. So they didn't have full protection. And if you look at these first 2 maps, the upper part, the minimal one, the areas with the paler green are the areas where diphtheria seems to be moving around now. So those areas have lower than even the 41.7%. So there's transmission going on here. And you look at full protection, only 41.7 had full protection. And for long-term protection, it's only 6% of children in Nigeria had long-term protection. So it's a really, really low number for us here. And they also noted that as after the primary immunization, the antibody level, immunity actually drops deep down to 4. That's why they need booster doses. But in Nigeria, they found out that in adolescents, they have higher antibody level. And the explanation for this is because diphtheria is still moving in the community. So the antibody level is from the infection itself, not from the vaccination. So because people are getting infection, that's why they are developing antibody. And you don't want them to get the infection. So it's better to give the vaccination and prevent them from getting the infection so that they do not die. And they also said that the rural areas were better protected than the urban areas in their own study. So the challenges we face with diphtheria in Nigeria now, we have a very low vaccination coverage. there is vaccine hesitancy. People are not taking vaccination because they don't trust the vaccine, or there are a lot of myths going on and misinformation in the space, in the media and social space. Then we have a poor health system. We have poor surveillance. Somehow, I think there are a lot of diphtheria that are still in the community that really don't come to us in the hospital. There's antimicrobial resistance. There are multi-drug resistance strains that are coming up now. The COVID pandemic hasn't helped us a bit. It took us back because there was a lot of focus on COVID and other diseases were kind of initially neglected. Then there are conflicts and insurgents. Vaccinators can't go to certain areas to vaccinate children. So those children are not protected. There is insufficient public enlightenment. Nobody's talking about diphtheria. You need to make a lot of noise about diphtheria because this is a very fatal illness and mortality is very high from this illness. So you need to talk about it. Then there's increasing population growth. A lot of people have poor housing. Overcrowding is the major problem with the cost of living now. So we are still have to fight that if we want to stop diphtheria. Then a poor sanitary and housing condition. Another group of people also look at other factors that they think are contributing to diphtheria in Nigeria. And they found out that there was insufficient DPT supply in Nigeria. And there was inefficient cold chain. And there's a low uptake, which is the vaccine hesitancy as well. And due to poor health literacy, people don't know anything about what we are talking about. They don't understand us. They don't know what it's all about. So they refuse vaccination. Then there's a negative sociocultural and religious belief. And that they also find that that was not available because the cost of production of that is very, very expensive. And they are recommending that our indigenous companies begin to look for ways of producing diphtheria antitoxin in Nigeria. So what is the major challenge we are facing now? If you look at the statistics of Nigeria, Nigeria has 44% of children or people who are less than 15 years. So that comes to about 95 million. And now we have a poor primary immunization coverage. We have a large pool of zero-dose children, 2.2 million now currently now, of children who have never been vaccinated at all. The booster doses are not routinely given in our centers. And when it's available, it's expensive. You have to search for it in the private sector, it's expensive. They have a poor cold chain system. So these are a lot of factors that are contributing to us that we are not getting vaccination. Children are not being vaccinated. So Nigeria needs, from my calculation, need 100 million doses of diphtheria vaccine. And I think we should vaccinate every child less than 15 years. And it should be done simultaneously. We should do mass vaccination, but it's going to come with a cost. And I think we should even do 2 doses for every child, so I know that they are covered. That would be about 2 million doses. I look up the cost of vaccine. A vaccine costs about $10 to $20. And in the next slide, we are going to look at the vaccine financing, how much it's going to cost us to achieve this. And I think the best approach for us to vaccinate children might be through the school health system. But however, we have some children who do not go to school. So we have to do door-to-door vaccination and leave no child behind. Now, we don't have intravenous preparation of antibiotics. From my experience on the world, those children don't take the macrolides in the first 4 or 5 days. They just can't swallow. So we give them ceftriaxone. We need to make that available also. We need to improve our sample collection and storage and transport because we are having clinical cases of diphtheria and we are not growing anything on the lab. I think it's the method of our collection that's defective. Then, of course, antimicrobial resistance is also setting in. So we need research on new antibiotics. We have very few antibiotics to play around with. We need genomic studies. These strains, are they developing resistant strain? Are they resistant gene on those on the strains available circulating in our environment? Those are the things we need to find out. Then we need to do surveillance. Like I said before, I don't think we have seen all the diphtheria cases. They are not reporting everything. Some are in the community that nobody actually know what it is, and they never might come to the hospital. So looking at vaccine financing, how do you go about it? A vaccine costs $10 to $20 per dose. In this publication, they said as of 2020, Nigeria will need $450 million annually to sustain vaccine production, vaccine in Nigeria, to give vaccines to children in Nigeria. Normally, what usually happens that this money is shared between the government of the country and international partners like Gavi, UNICEF, and World Bank. But Gavi is also telling countries that they need to take off vaccine supply themselves now because, and of course, Nigerian population is also increasing. So if you look at 100 million or 90 million children, you can put how much this is going to cost us. If you convert the $450 million is about $650 billion. And that's almost taking the whole of our head budget. Our head budget is 2.8 trillion. It's taking a large chunk, maybe like a third or fourth of our health budget. So it's a big challenge for us. So we have to find ways to increase funding. And some of the suggestions include that the tax from telecom and internet user, which is a huge amount, the government should put that into vaccines, because vaccines need to be provided for these children. The health budget is small, and it's not enough to get vaccination for children. And you need to do local production as well. So you have to reach every child wherever they are, wherever they live, they must be vaccinated. That is the only way to go about this. So in conclusion, I would like to say that diphtheria is still on rampage. It hasn't stopped. It's still moving. We must stop it, and we have to stop it on time. Thank you.
Well put together presentation. It's now time for us to entertain comments and questions. If you have any question or comments, you can actually type it on the chat box, or if you want to speak, you can actually raise up your hand digitally, and then we'll ask you to please unmute. I believe it's a very insightful meeting we've had. I've learned a lot, and I think in our advocacy, there are things we need to take from this presentation. So anybody that wants a comment, question, you can actually type in the chat box, or you can raise up your hand digitally, and you'll be recognized to go and maybe just unmute and speak. I'm trying to scan if there's anybody whose hand is up, or if there's anything on the chat box. I can see a lot of combination for what has been done. I think Dr. Akintan has done a very good job and a superb overview. So question and comments are now welcome. Okay. You can meet my prof.
Thank you. Thank you very much, Dr. Akintan. You know, you have refreshed my memory once again about how we used to labor over children with respiratory obstruction. So the first thing I want to say is that it's not, you know, it's not really difficult to separate those children who have come with lower respiratory obstruction from upper respiratory obstruction. Their mode of breathing is quite different. With the lower respiratory, it's a wheeze, whereas with upper respiratory, it's a barking sound like we call it croup. I noticed that you didn't mention, you know, you didn't use the word croup, or maybe I joined late. In those days, we used to call it croup because of the sound that you get. So I want you to mention that. And now, concerning vaccination, it's a pity that, you know, over the years, we have not actually been able to take care of our own vaccination, the vaccination of our own children, without resorting to getting aid from Gavi, etc., etc. And, you know, as things go on, we see that these institutions will leave us. They will just, you know, because they too, they're struggling to increase their health budget, particularly in the United States. You can see that in the United States, they are reducing their attention to giving medical care to everybody. And it's being reflected by the policies that are being made now. And in fact, you know that the Secretary of Health in the United States, you know, has a very a negative, you know, not attention, but, you know, negative way of looking at vaccination. I'm sure you have heard about that, you know, he thinks that they're making too much fuss about this vaccination. And why does he think so? Because they want to cut down on the budgeting for immunization. You know, they've enjoyed freedom for so long from vaccine preventable diseases that he thinks that, okay, they are now at the end of the road and there's no need to pay so much attention to these diseases. So there's politicization of immunization in America now. And I'm sure that will have a backlash on the way they are going to assist us. So it's very, very important that we take this seriously and start to do serious advocacy with the public health sector. There should be collaboration. In the past, in LUTH in the past, there was collaboration through the PHC, through the primary healthcare development institution, you know, which I actually had the opportunity to head at one time. But that has been taken away from pediatrics, or from all the doctors, and it's been given back to the community health. Unfortunately, because of that, community health continues to do their own thing separately from the clinical departments. I believe that as pediatricians, we have to continue to work with them and advocate with them, and have, if possible, even have some time when we post our residents to the community together with them. This is what I would suggest, because things are happening now that is going to reverse all the gains that we have had in child health programs. I'm so worried about that. The second aspect, the second way of getting pediatricians to participate vigorously in this is by making sure that the children that have come through their care, maybe through the emergency room, through their wards, etc., are followed up, and we make sure that eventually they do get immunized. When I was when I was the head of the pediatrics, I got a section developed, attached to the department, to the emergency room. I don't know if it's still there now. The idea was that children who were discharged from the emergency room should be seen in that space where a nurse reviews their treatment, what follow-up, the follow-up advice, etc., and make sure that that is carried out. I don't know if that is still being done, but it's like having a community care area for pediatricians, and particularly for the residents who will learn more about community care through that section. I think, Dr. Akintan, you are you are at LUTH.
Yes,
So I would like to hear from you whether that is still going on.
Okay.
Thank you very much. Thank you.
Thank you.
Thank you very much. Let me just read some comments on the chat, and then some questions you might need to respond to. There's a comment from Dr. Rufai. Say, well done for the presentation. From my center at Sokoto, we had a lot of diphtheria cases this year. In fact, in the last 3 years, we have had close to 280 children with disease. Most of them have multiple complications such as cardiomyopathy, nephropathy, and bleeding diastasis. We have sudden death. Most of them affected were females. So the follow-up question was that, is there any role for chemoprophylaxis with azithromycin as a preventive measure? And do you have any information about why females are more at risk to this? And I think also Dr. Fandimo would like to be unmuted. Maybe after this response, we'll arrange for you to be unmuted. You have some information about what's happening in Kano because you are the lead focal person for Kano State. So Dr. Akintan can quickly go for it and then
Okay,
we'll have.
Let me talk about answer Prof's comments and the question. So the contact tracing we do in community medicine, like Prof said rightly, they've moved out of pediatrics, so we really don't have control much with them. But what we usually do, we usually call them and go to the community. But maybe it's the contact tracing is not very robust, I must say. You know, it's not very robust at all. So that's a big problem, being challenged. And the drugs are not free, so patients have to get it themselves. We are not even sure even they are getting the prophylaxis. So what we focus more is our own patients in the hospital. The community help people do that. So it's not very robust, to be honest. So that needs to be awakened. And then the child survivor, the unit is still there at the back of emergency room. And like Prof said, I think we need to be more conscious that any child that comes to us, we need to do a thorough immunization history. Has this child been vaccinated? It will be unfair if a child passes through the system and comes back with diphtheria later. So that's well taken. Then about this, the group, yes, is well taken. It's upper airway that they have more. I'm trying to see any other thing that I missed in pro. Then some of the comments made were very, very useful. Thank you so much for the comments. The question about, is it INH or is it azithromycin?
Azithromycin as prophylaxis.
For contact.
Yeah, as a preventive measure. Can you? So, is there any role for chemoprophylaxis with azithromycin as preventive measure? And why are females, children more at risk in this disease process? Do you have any information about that?
I'll take the second one first. The second question. In my search, I didn't find anywhere where girls were more affected. Maybe that might be their nutrition. I have no answers to that. I must confess, but it affects both male and female equally. What is important is your immunity. If you don't have immunity to diphtheria, then you get down with diphtheria. So there is no gender or sexual predilection. It affects both male and female. So no studies have shown that. Maybe that's something we need to look out for. Maybe our own environment is different, but no, all the studies, both male and female are affected equally. Then prophylaxis is only given for people who are contacts. You need to think of antimicrobial stewardship itself. You can't give erythromycin to everybody. If people are contact, they should get antibiotics. Anybody who is a contact, take a throat swab and they should get antibiotics. We are not doing throat swab for contacts in Nigeria. Nobody does it. And the antibiotics, we are not sure they get it. They say go and buy. Nobody knows if they really go and take these antibiotics. And they might be carried in their airway for a long time and transmit it to other people. So you only give prophylaxis for those who are contacts to the patient. Yes, it's allowed. I hope that answers your question.
So is azithromycin recommended? What we recommend? Azithromycin or what other antibiotics?
We either use erythromycin or azithromycin. Azithromycin is once a day, so it's easier for people to take once a day and they don't forget. So I prefer azithromycin my personal choice is azithromycin for prophylaxis.
Thank you, Ma.
Yes,
so is there any way we can meet Dr. Fatima? She says she is a focal person in Kano State and head of pediatric IDs in American Hospital. Can you help us? Can you please, Dr. Fatima, maybe you put up your hand digitally, then we can recognize you and then unmute you. Dr. Fatima Azan, if you can put up your hand digitally, then we can recognize you and then unmute you for you to make contributions since you're a focal person in Kano State.
I've unmuted myself.
Go ahead, Fatima.
So don't go ahead, please.
Okay, good afternoon, everyone. Yeah, thank you very much, Dr. Akintan, for that excellent presentation.
Thank you.
I just have a few comments. One, it's quite important. It's nice that we have immunoglobulins can be given and that it's more effective than that. but that data is not even available for us to use for our patients. It's not always available. Much of the time it is not available, so that it is very traumatic actually watching your patient actually die before you. There's nothing you can do when they come back with these complications. Cardiomyopathy, cardiac complications. In our center, we have like 50% mortality from cardiac complications. The issue of immunization is the most effective method for prevention. But despite the fact that Red Cross has recorded a 90% acceptance of vaccination in our area, UNICEF and WHO have recorded that the vaccines are inadequate. We are a population of over 12 million, and a large number of population, 60% of the population is under 15. So it's a massive number, but neither the federal government nor donors have been able to give us adequate vaccines to vaccinate the children that need it. Those are under 5. On azithromycin, there is room for azithromycin prophylaxis. And actually, it may be the most effective way for Nigeria to go, considering that we have no access to the vaccines. We say that we are a poor nation, even though that we have the technology. We do not produce the vaccines by ourselves. So we depend on donors to bring us vaccines. So azithromycin prophylaxis actually will quash the outbreak anyway, because once you give azithromycin to all children under 5, you will be able to break the transmission of Corynebacterium diphtheria. And in that case, you'd only need 27% of vaccination. So that is more important, I think, for us to look forward, despite the fact that there's a scare for antimicrobial resistance. I think actually for us to break the transmission of diphtheria, we need to go the azithromycin way, prophylaxis. And there have been several studies actually that have documented that. Truelove et al. Has documented that the best method to break transmission of diphtheria is through prophylaxis, either azithromycin or erythromycin. Considering the mode of administration, I think azithromycin will be a better way to go, inshallah. So thank you very much. Those are my comments. And congratulations for a very brilliant presentation.
Thank you.
Thank you, Dr. Fatu. I see Dr. Bubakar Usman's hand is up. Can you please unmute and speak, please?
Good afternoon, sirs. Thanks for the beautiful presentation. I'm calling from Federal Medical Center, Bida. It appears we suffered the last outbreak. We just closed our isolation center about a week ago, because in the month of October alone, we had about 50 children admitted as case of diphtheria. Our major challenge, actually, now out of these 50, we discovered that nearly 99% did not receive any vaccination, which is what the presenter has actually hammered upon. But as an institution, we had this major challenge of non-availability of the antitoxin. Most of them will come down with the complications, cardiac, renal. At that point, you're just doing supportive management, and we had a very high mortality. So I don't know what the country is actually doing. Apparently, diphtheria appears to be forgotten in the last 2 years, and no enough stock of the anti-diphtheria toxin available in the country. It was actually a very challenging issue for us. And I felt I should just raise this. It is a way we can actually secure the availability of this antitoxoid. It will go a long way in helping the nation at large. Thank you very much, sir.
Thank you, Dr. Abubakar, for your insightful information. Any other question or comment before we close the meeting?
Sorry. Let me address briefly that issue of advocacy for drugs, immunization, etc. I think you have to carry this thing beyond the government. If you remember, when we wanted to tackle HIV/AIDS in children, we had to even go to pharmaceutical industries, etc., to give us cheaper drugs. You know, we cannot afford to just limit our advocacy to the government now. And that's what I'm saying, that pediatricians by themselves need to find a space where they are carrying out strong advocacy with or without the public health physicians. Otherwise, we are going to be in a very bad situation where we are losing all the children from preventable diseases. And by the way, we are now focusing on just diphtheria. What about if we weaken the immunization, if the anti-tetanus immunization process is also not being carried on, and then we run into the problem of intergenerational tetanus prevalence, higher prevalence, because the mothers have not got a high tetanus what do you call it now, immunization or whatever. And so by the time they now become pregnant and all that, their children their babies are more susceptible to tetanus. So we can't continue to do things piecemeal, and we have to really focus on what we do to take care of a comprehensive care of vaccine preventable diseases. And that has to do with routine immunization. Routine immunization, unfortunately, that is going down for many reasons that Dr. Akintan has outlined for us. But, I don't know. I believe that this area belongs to the infectious disease group among pediatricians, isn't it?
Yes, sir.
So please take it very seriously. Otherwise in 5-10 years time, I may not be here, but you'll be dealing with things that we are supposed to have been gotten rid of long ago. Thank you.
Thank you, ma. I can see Ifedayo. I assume it's the same Ifedayo that I know. Please, can you unmute and speak, please?
Also, there's another question that
I know, I'll read that. I don't want Dayo to speak.
Right. Yeah.
I have read the question.
Yes, Ifedayo should speak. Well done. Thank you.
Good afternoon, Prof, and good afternoon, everybody. Sorry I missed most of the talk because I had to go. So, but I just wanted to make a quick comment apparently I've heard about the challenges with not having diphtheria antitoxin and enough doses of vaccination. I want to suggest to NISPID and perhaps through PAN to perhaps write now to the health oversight committees in both the Senate and the House of Rep, so that perhaps and to follow up and to see if they will be triggered to ask the necessary questions about why there's not enough budget allocated for that, and perhaps also for the vaccine doses that are required for the catch-up campaigns. We did try to make that available in my time at the NCDC, but I recognize that that's probably come from me being a pediatrician and being able to move resources around to make that possible, and also press WHO and others. But perhaps we do need a bit more engagement to bring the same level of understanding to those that are responsible. If Nigerian children are dying of what is otherwise a preventable disease, I think this needs to be brought to the attention of the House. We have often been placed under pressure by receiving letters from the House or Senate oversight committees asking particular questions about outbreaks. So that might be a useful thing to consider doing. Thank you.
Thank you, Dio. Thank you very much for your insightful information. I think that's what we can
Thank
carry out
you.
for us.
Thank you, Dio. You know, you have faced the music when you were in NCDC. Well done for all you have done. Thank you.
Well, there's a comment that at least Diphtheria was the first to bring that to the country. So that's kudos to you. So there's a question here. Thank you very much for your presentation. For this, please, ma, how often are we healthcare personnel to take prophylaxis? Like there was a time in my center we are seeing diphtheria every day for almost a month. So what will be your take for healthcare professionals about prophylaxis when they're exposed to this disease? Dr. Akintan. Hello. Is she still around? Well, I can't seem to see her. Okay. Is there anybody that can actually help with that? Anybody in infectious disease that can speak to that? Prophylaxis for healthcare workers at risk. What will you?
Yes, sir. Thank you.
Okay.
Fatima Hassan Hanga speaking.
Yes, go ahead.
Go ahead, Fatima.
One has to be sure that he has had a vaccination in the last 5 years. That's number one. Secondly, then, if you have come into contact with the patient, then you should take azithromycin as a prophylaxis. Thank you.
Thank you very much for that comment. So, Bob, okay, so any other comment or contribution before we close the meeting? And for me, my takeaway is a very strong point for advocacy. And I think January should be a pointer where we need to talk about these problems that we have and maybe make it more global, like advised by Professor Grange, that is not just diphtheria alone. And I think that also alluded to that we need, as PAN, begin to just speak to these issues about vaccination of children and the challenges that we have with them. And again, I think we can use our goodwill beyond government, like Professor Grange advised, that we can start talking to industry also. And I think we have enough connection within the system, political connection, social connection, to bring to bear. And I think it will be a good rallying point, at least. Our chairman is in PAN executive. I think we need to also bring the issue of vaccination, using diphtheria or any other issues at the focus for our next conference in Abeokuta. I yield back to my chairman, Dr. Letu, for final thoughts.
Sorry. Let me just say one thing. There's another area you can link up with some of us pediatricians, some pediatricians who are in the diaspora, to assist in maybe making sure that the assistance that we are getting from abroad is not cut off immediately, and that there is, more dialogue between the pediatricians at home, in the diaspora, as well as those who are assisting us to immunize our children. Okay, I hope you get that line of thought.
Very much.
Yes, thank you.
Thank you very much. So, I think we're also going to rope round Daya. I know you're doing something around somewhere in the space, so we won't leave you alone. We'll talk to you and ask for counsel on how to approach these issues. But I think, Dr. Letu, I think the ball is your court now. You are in PAN executive. Daya has given us a challenge. I'm sure we need to actually push for the agenda in Abeokuta. Thank you very much.
Okay, thank you very much, Dr. Dushote. First, I want to thank Patricia Akintan for this lovely presentation, and of course the reaction that it has generated. When this topic was first chosen, we were thinking maybe we won't get many people to attend and they may not even see it as a major problem. But we've now realized that this is a serious problem ahead of us and we need to tackle it. And some of the suggestions that have been made will be passed on to the PAN executive so that we can work on it. I'm also very happy that one of the sub-themes for the conference in Abeokuta is looking at emerging and re-emerging communicable diseases, a case for local vaccine production. So obviously, this is also something that's been in the mind of the LOC of the Abeokuta PANCOF. So this will also generate more discussions, and hopefully we will have written to the necessary houses before, that's the Senate and the House of Assembly, before the conference in Abeokuta. So we hope that one or two of them may even attend, and it will be part of our communique at the end of the conference, so that we just make everybody aware that these are issues that we still need to talk about. And it's even more topical now. If you look at what's going on in a country like America, you can imagine what the anti-vaxxers are doing. And it's even something that a lot of people are discussing in Nigeria. I got a mail on the platform I was on yesterday, and I was really very upset that somebody who is so educated will be talking about why is government going to spend so much money to vaccinate our children. I just thought that, I mean, education is still very important, and we need to still do a lot more advocacy, even to those whom we think should know, but maybe they've just chosen to close a blind eye, or turn a blind eye to the issues we're talking about. So I'm happy that we've had this discussion and we'll continue to have it. I will pass on the message to the PAN president and the ESCO so that a letter can be forwarded immediately to the necessary agencies for them to act, if it's still possible, since the budget hasn't been passed, or the budget has, I'm not sure the budget has even been read anyway. So if it's still possible to put a line for this kind of program that we're talking about. So I want to thank you again to everybody who has participated, particularly those who have joined from the diaspora. Professor Grange, as usual, I want to say a big thank you to you, Ma, for attending. Dr. Mbolaji Lawal, Dr. Agbato, I saw Dr. Fakunle, Dr. Oshodipo. I mean, they're always here to support us. And for those of us who are in Nigeria, we want to say thank you again and ask at every point in time that we call upon you, you join us to look at issues that affect Nigerian children. We will skip December because the next meeting should have been on the 25th of December, which is Christmas Day. And I'm not so sure that we'll be eating chicken and rice, and I'm not so sure that we want to listen to any presentation. So hopefully we shall meet again in January after PANCOF. And I want to, on behalf of the ESCO, also oh, okay, Fatima, your hand is up. Is that a new hand?
Clapping.
Oh, okay, clapping.
She's
all right.
clapping.
So we want to advise that we all register for the conference and attend. The conference will be between the 21st and 23rd of January in Abeokuta, which is close to Lagos. And of course, Ogun State now has an airport, so it's easy to fly in from Abuja to Ikperu and then just take a 20 minutes drive to Abeokuta. So hope to see you in January, God willing, and have a lovely day. I yield back to Dr. Dushote. Thank you.
Thank you, Dr. Lisu. So it's announced that we're going to take a break. So we'll see you in the new year. And the prayers that all of us will be sound, healthy, and as zeal to continue to push forward the agenda for the Nigerian child will not relent. So like I said, we also look forward to meeting everybody in Abeokuta. I think for us as a group, there's an agenda to push: vaccination, and funding for other programs that's germane. So we look forward to seeing you in the new year, and God bless.
Thank
Thank
you.
you all.
Good.
Thank you all.